How's it going, guys? So we have on the surface a difficult question for both family and internal medicine for 2CK, but as I explain a couple important factoids here, you're going to see this actually isn't so bad, okay? And I'm going to tell you some important factoids that will increase your score. So before we get started, I will be my frequent asshole, tell you to subscribe to my channel. I really appreciate it. Give the video a like, I really appreciate it. Find me on Instagram at Mehlman_medical, MEHLMAN_medical, link is down below. Find me on Telegram. Recently created a Telegram group and channel. Links are down below. Now let's start the clip. So 56-year-old woman, 7-year history of type 2 diabetes mellitus. She's on metformin and glyburide. BMI is 35. Blood pressure elevated at 160/90. HbA1c high at 9.4%. You should know diabetes mellitus is 6.5% or greater for HbA1c. I don't want to get crazy tangential, but you should know that normal fasting glucose should be 72 to 99 milligrams per deciliter. Impaired fasting glucose is 100 to 125 milligrams per deciliter. 2 fasting glucose measurements of 126 or greater is diagnosis of diabetes mellitus, or any one random glucose measurement 200 or greater, or an HbA1c of 6.5% or greater, as I said. Now, they can give you a normal glucose measurement, but an HbA1c of 6.5%, answer is diabetes mellitus. So serum urea nitrogen is elevated at 35, should be 20 or under. Creatinine is elevated at 2.6, should be 0.7 to 1.2. And our hepatic transaminases are within normal limits. And then the question asks for seemingly nitpicky modifications to the diabetic regimen. Now, before I hop into this, I want to tell you a very important factoid, which is that this patient also needs an ACE inhibitor such as lisinopril or an angiotensin II receptor blocker such as candesartan, even though it's not the focus of this question. And that's very high yield for family medicine. And the reason is because you will commence an ACE inhibitor or an ARB if the patient has a blood pressure, if a diabetic patient has a blood pressure greater than 130/80, or elevated creatinine, or elevated renin, or protein in the urine. Okay, very high yield. This patient, blood pressure is clearly greater than 130/80. Patient clearly has elevated creatinine. They don't mention renin or protein in the urine, but I mean, these are two indications right away where some questions might say add lisinopril or add candesartan. Very fucking high yield, okay? Now, addressing this diabetes stuff, and I said, once I tell you some factoids, it's not going to be crazy difficult. Metformin can cause lactic acidosis. So if you get a question where there's low bicarb, you know you have to discontinue it. They didn't give us the bicarb here. But metformin should not be taken in patients who have renal insufficiency because of the risk of lactic acidosis. So you know right away we should be discontinuing the metformin. So when we look at the answer choices, okay, even though these are seemingly complicated, it's like, holy shit, like, what do we do? Just relax. Choice A and choice B, they don't address the discontinuation of the metformin. Choice D says increase the dose of the metformin. I mean, you know right away A, B, and D are wrong fucking answers. Okay, I mean, it's just that simple. In addition to the fact that, okay, actually, I'm going to add one more piece of information first, which is glyburide, a sulfonylurea, an insulin secretagogue, requires functioning beta islet cells. So the elevated HbA1c in the setting of being on a sulfonylurea indicates that this drug is not demonstrating efficacy in this patient, so we don't need it. So choice A causes polypharmacy. Okay, that was the other point I was going to make, is not only do we not discontinue the metformin, which we need to do, but it's polypharmacy. Family medicine, that's an important cause of morbidity in patients, is unnecessary polypharmacy, not removing drugs when they should be removed. So we need to get rid of the metformin because of lactic acidosis risk and setting of renal insufficiency. We need to get rid of glyburide because it's clearly not demonstrating efficacy as the HbA1c is high. Patient likely no longer has functioning beta islet cells. Pioglitazone, I've never seen adding thiazolidine diones as a correct answer on any NBME assessment. You could be aware somewhat peripherally that can cause cardiomyopathy and hepatic insufficiency. I mean, our hepatic enzymes are within normal limits. Pioglitazone in particular also increases the risk for bladder cancer. Choice C, discontinue metformin, which is what we want to do, but increase the dose of the glyburide. As I just fucking said, the patient doesn't need to be on the sulfonylurea because clearly it's not doing its job. Okay, so we're not going to increase the dose. The patient likely doesn't have functioning beta islet cells anymore. Choice E, switch from metformin and glyburide, which is getting rid of those agents, which is what we want, to intermediate acting insulin. That is correct. Now, the USMLE does not expect you to be in the overwhelming majority of questions, okay? Does not expect you to be an endocrinologist where OMG, is it like short, intermediate, long-acting insulin? If they make that the focus of the question, they will give you very difficult array of glucose measurements at different times of the day, and you sort of have to implement reasoning as far as when a certain type of insulin might need to be added or removed. That's where they might get technical. It's pretty rare, but it can happen. But for a question like this, it's just it's the insulin they gave. It happens to be intermediate acting insulin. We avoid polypharmacy. We get rid of the metformin. We get rid of glyburide, and that will satisfy this patient's diabetic medication requirements. As I said, not crazy difficult once we explained it, but on the surface, it can seem nitpicky and difficult. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.